Welcome to this evening's COVID-19 series, webinar topic 2, treatment of COVID-19, what works and what does not. This webinar provides healthcare professionals the opportunity to have your questions answered by experts in their field. The program is hosted by PraxHub, presented by the Immunisation Coalition, and is intended for healthcare professionals. I'd like to acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this webinar. Right now, I'm on Wurundjeri land of the Kulin Nations, and I pay my respects to elders past, present, and emerging. And we recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. My name is Peter Eisenberg, and I will be your facilitator tonight. I'm a GP and Director of Doctors of Ivanhoe in suburban Melbourne, and formerly the Chair of North East Valley Division of General Practice. I'm a current member of advisory committees for AUSVAC Safety, the National Vaccine Safety System, and the Immunisation Coalition, the expanded influenza specialist group. I'm a current or former member of several government immunisation committees and other national advisory groups. I also have a special interest in vaccine research with over 20 years experience as a clinical investigator for a number of new vaccine trials. Now please make yourself comfortable as I introduce our first distinguished speaker, Associate Professor Stephen Tong. Stephen Tong is an infectious diseases physician with the Victorian Infectious Diseases Service and co-head of the Translational, Clinical Research and Indigenous Health cross-cutting disciplines at the Doherty Institute in Melbourne. His research interests include skin pathogens, hospital infections, Indigenous health, viral hepatitis and influenza. Stephen currently leads 2 large adaptive platform clinical trials which study the effect of multiple potential interventions. These are for the Staph aureus network adaptive platform trial, called the SNAP trial, and the Australasian COVID-19 ASCOT trial. So Stephen, with your knowledge of COVID-19, please walk us through what treatments work and what don't.
Thanks very much for the introduction, and we'll get going through this. Thanks, Peter. So, of course, we've got to start with Donald Trump. As you all know, he was diagnosed with COVID-19 probably a couple of weeks ago now, and he received lots of different treatments. So I've listed them here. So his doctor, I guess, provided an open letter to everyone saying that these are the things that Donald Trump got. So Remdesivir, Regeneron antibodies, Dexamethasone, zinc, vitamin D, famotidine, melatonin, and aspirin. So my question is, I've got 2 questions here. The first one is to get a sense of how many of you have been involved in the management of patients with COVID. So again, everyone's going to be correct with their answer. Okay, so about a fifth of you have been involved in direct patient care. Great, that's very helpful, thank you. So I've got a second poll then. This is for everyone as well. According to the existing clinical evidence and guidelines, Trump should have received which of these following answers? Remdesivir, Dexamethasone, Regeneron monoclonals, Hydroxychloroquine, or could it be all of the above, or is it none of the above? And just to remind you that Donald Trump, I guess he was hospitalized, but wasn't necessarily hypoxic. Apparently that he might have dipped his oxygen saturations a couple of times, but let's just say that he wasn't. All right, so got a pretty nice mix there. And that's, I think, often the case when there's not necessarily strong evidence for one particular treatment or the other. And we'll go through pretty much all of these things to discuss them during the course of tonight. Either Gary or I will cover off on most of these. So we'll keep moving. Thank you. So the outline of my part of the talk will be, we'll discuss Remdesivir, we'll discuss hydroxychloroquine, Ivermectin, convalescent plasma, and I also wanted to have a couple of slides about the ASCOT study which I lead. So starting off with Remdesivir. So I'm on Twitter. Some of you may be on Twitter as well. Obviously, Donald Trump is on Twitter. And on April the 30th, I wrote this because I woke up in the morning and, I don't know, as probably many of you do, I check my phone and I check Twitter. That's actually one of the ways which I get a lot of my updates and my news. And I woke up to see massive news about Remdesivir. There was a publication in The Lancet that showed no benefit of Remdesivir. And then almost exactly the same time, there'd been a press release from Tony Fauci regarding the clear benefit of Remdesivir. And so we're kind of left in this space. Well, what do we do? What do we believe? Is it really no benefit, or is there some clear benefit? And this was going around on social media at the time. All right, so again, a bit of a rhetorical question, but during a pandemic, what should we, or who do you rely on for your information in terms of, I guess specifically here, treatment for patients with COVID-19? All right, nice one. So people aren't using Twitter very much, nor preprints. It seems like we generally feel that we should be waiting for full publications. And I guess, you know, a number also would say all of the above. And I look in my, I guess, use of the various things that are available would probably say all of the above, but clearly full publications provide the most information. And in this era of social media and press releases, it's been quite interesting seeing how things like press releases have very much influenced, I think, treatment and also preprints as well. So, you know, some of the studies have taken a long time to come out in the journals, and clearly there's been some influence on, I think, our management even before those full publications have come out. So Remdesivir is an inhibitor of RNA-dependent RNA polymerase. So the SARS-CoV-2 virus is an RNA virus. To make more copies of itself, it uses this enzyme called RNA-dependent RNA polymerase. It's a very common feature of many viruses. And it's a clearly very important part that the virus can't cause any replication without this enzyme. And so it just happens that this drug Remdesivir, which actually wasn't designed for SARS-CoV-2, it was designed initially for hepatitis C. It was shown to have some in vitro, so in cell culture, effectiveness against Ebola as well, but ended up not being clinically effective in Ebola. But it's been shown in a number of studies, basic laboratory studies, to have quite good activity against SARS-CoV-2 in a cell culture system. And there's been really 3 major randomized controlled trials looking at Remdesivir versus patients who don't get Remdesivir. One came from China, which is the Wang study here with 237 patients. A study, the Beigel study in the New England Journal of Medicine, which was sponsored by the NIH and the NIAID, and that's the one that Tony Fauci was talking about, and then a publication in JAMA as well. So you can see that overall we have about 1,800 patients who've been in clinical trials with this drug. So I'm just going to step you through these studies to give you a sense of, you know, how these are designed and what kind of evidence, what kind of patients were involved in the studies. So the first one was the Wang et al. One published in The Lancet. This was based in China and an investigator-initiated study. Patients were those who were about within 12 days of their symptoms. Their oxygen saturations, which normally should sit, you know, 96% or above, were less than or equal to 94%. These patients had chest X-ray changes, and they recruited 237 patients in total and randomized them to 10 days of Remdesivir versus a placebo. So that it was actually a blinded study where the placebo patients received an infusion of something like normal saline. So just Remdesivir is given as an intravenous infusion. It's a 200 milligram bolus infusion to begin with on the first day, and then for subsequent days, it's 100 milligrams. The primary outcome in this case was a time for patients to achieve clinical improvement out to day 28, which was when they really stopped the follow-up of those patients. It was interesting that, we were obviously all looking at China and seeing what would happen early on. This was during February, March, and this study was stopped due to the good control of coronavirus that occurred in China at the time. And they found that there was a similar mortality in both treatment groups. One of the, key things is that all these studies use this clinical improvement scale. So patients are rated on a scale at baseline and then at the point of follow-up and during the course of their follow-up. And as you can see, as we progress through the stages, patients are getting more and more severe in their score. And what most of these studies are looking at is, at what point in time do patients get home, basically, or do they get off oxygen? And the other main outcome is whether people die or not. So in this case, in this weighing study, we can see the Kaplan-Meier curve here, and that shows over time. So on the x-axis, time since the start of the study, cumulative improvement rate on the y-axis, and basically there's no difference between these two groups. Perhaps the Remdesivir receiving participants got better a little bit more quickly, but it was certainly not statistically significant. So that's study number one. And then when we looked at the mortality, it was 14% in the Remdesivir group, 13% in the control group. So no difference there. In the Beagle study, which was the largest study, this was conducted all over the world. Similar group of patients, oxygen saturations less than 94%, or chest X-ray changes, about 1,000 patients, 500 or so in each treatment group. And their primary outcome was this time to clinical recovery out to day 28. So actually the final results of this just got published this week. And if we look at the overall patient group, again, we've got similar axes, days along the x-axis, the proportion of patients who recovered on the y-axis. You can see that the Remdesivir group recovered at a more rapid rate. And by the time we got out to day 28, a larger proportion of patients had recovered than those who received placebo. And at a median level, patients got better and out of hospital after about 10 or 11 days when they got Remdesivir, compared to 15 days for the patients who got the placebo. And this effect was most marked when we looked at different subgroups for the patients who are receiving oxygen in this panel C. So there was little difference for those who were not receiving oxygen. There was no difference for patients who are on high flow oxygen or needing mechanical or non-invasive ventilation. The treatment effect was mainly seen in those who are receiving oxygen, supplemental oxygen, but not particularly sick at that time with it. So I said the clinical improvement was 10 days versus about 15 days. And the mortality, I think this is kind of clinically relevant. So in the Remdesivir group, about 11% of patients died versus 15% in the control group. This was not statistically significant, but it's certainly heading in the right direction. Then the final study was again a global study. This was a less severe group of patients. So they had oxygen saturations of greater than 94%, even though they had chest X-ray changes. And the primary outcome they were looking at was clinical status at day 11, and about 200 patients in each of these groups. This was an open label study. And here were their outcomes. So if we really just concentrate on day 11, which was their primary outcome, this is a graphical representation of that score that I showed you before. And this kind of light bluish color is the proportion of patients who were discharged from hospital. And what they demonstrated was that patients who got Remdesivir either 5 days or 10 days were more likely to be out of hospital by day 11 than those in the standard of care who didn't get Remdesivir. Notably, there was no difference in the mortality rate, but if you look at the kind of dark blue lines out here, out at day 28, very few patients died in this kind of fairly mild group of patients. And that just kind of repeats what I've said there. So summary is that there's kind of clinical benefit in the time to clinical improvement. Patients seem to get out of hospital more quickly if you get remdesivir. It's best in those who require supplemental oxygen, but there's not really any clear, at least statistically significant benefit in terms of saving lives. And 5 days of remdesivir seems to be similar to receiving 10 days. So the National COVID-19 Clinical Evidence Task Force is a group, quite a large group actually, that's been gathered together of experts around Australia. And they've made recommendations for all kinds of different therapies for COVID-19. And so their recommendation for remdesivir is that the benefits outweigh harms for the majority, but not for everyone. And their view is that the majority of patients would likely want to receive remdesivir. And so how do we access this in Australia? Well, there's a national medicine stockpile as an online application form. So for the patients who meet these inclusion criteria, so oxygen saturations are less than or equal to 92% on room air, they can qualify for remdesivir. There are certain exclusion criteria. So if they're very sick, if they've got multi-organ failure or renal failure, or if they're on mechanical ventilation for longer than 48 hours, then they're excluded from receiving remdesivir. There are some special considerations, and again, there's a bit of nuance. So at places like the Royal Melbourne Hospital, we have actually a panel of 3 people who assess each patient to determine whether that we should apply to use remdesivir for that patient. So I'm going to move on to hydroxychloroquine now. So there was some early data about hydroxychloroquine. So this came out of France. This was an observational trial where they followed patients out, I think it was out to about day 10 or so, and looked at the viral load of these patients based on a swab and a PCR. They indicated those who received hydroxychloroquine were likely to clear their viral load more quickly than those patients who didn't receive hydroxychloroquine. Now, this was observation, was uncontrolled. They were just describing their experience. Of course, Donald Trump picked up on this and tweeted that hydroxychloroquine and azithromycin have a real chance to be one of the biggest game changers in the history of medicine. A little bit of hyperbole. And so the FDA provided an emergency use authorization, which really broadened the ability for this to be used. And so Trump said, this should be put in use immediately. People are dying, move fast. God bless everyone. So my next poll is, if you cast your mind back to March, when we're in the midst of this first wave, we really didn't have much information regarding treatment, and perhaps this was the information that we had. What would you have done in the situation of having a patient come to you, be hospitalized? Would you give them hydroxychloroquine or not? Great, 50-50, love it. This was a real dilemma at the time. And for those who were treating patients, there were many who said, well, there's nothing to lose. We should definitely give, this medication. It's been broadly used. There's no evidence that it's not safe. But then on the other hand, there was a camp who said, well, we've never used it for patients with COVID-19 before. We don't know that it's necessarily safe. There can be some toxicity. We really should wait for further data before we give it to patients. So let's run through what evidence has arrived since then. So I guess I wanted to review what that particular study that I've described, where they had the different viral loads, and what we should think about such observational data. So this is some tweets from a professor of cardiology at Imperial College in the UK. He writes, we decided treatments are beneficial by doing scientific experiments, that is, randomized controlled trials. When people come up to me with non-randomized data on treatments, they're universally trying to make me believe in the therapeutic effect of the treatment. And he basically says he doesn't use this kind of observational data to influence whether you should treat things or not. He says this doesn't mean that he doesn't look at non-randomized data when he wants to know things like, well, what proportion of patients with COVID are men, or what proportion of COVID patients need to be ventilated, but never to see whether a treatment's good or not. that this observational data is not helpful. And that's partly because there's no control there. The decision as to whether to give someone treatment or not is influenced and biased by so many things, and it's almost impossible to remove all those confounders. And so it's heavily biased, the kind of data that's obtained from this observational data. And so he goes on and writes, he says, I just don't read such papers with observational data for therapeutic effects. Just like I don't count the blades of grass I walk past on my way to work every day. I could do, but it would be like a broken pencil. It's pointless. And I think that's become increasingly evident with COVID, that observational data really doesn't cut the mustard, and we really need randomized controlled data. So we actually now do have randomized controlled data. And again, this has just been published in the last week or so. In the United Kingdom, they've been running the recovery trial, which has been this amazing study, very pragmatic, and they've now randomized 10 to 15,000 patients to a number of different therapies. And one of those was hydroxychloroquine. So they had over 4,000 patients randomized to either hydroxychloroquine or usual standard of care without hydroxychloroquine. And their primary outcome was 28-day mortality, which I think is the most important. So we really want to know, does this save lives or not? And you can see on these Kaplan-Meier curves that there's a divergence. And in fact, if you look at the direction of that, there was actually higher mortality in the hydroxychloroquine group. Now, that was not statistically significant, but it is very clear that there's no benefit in this very large, well-conducted clinical trial. There's no benefit to hydroxychloroquine in this patient group of patients who've been hospitalized with COVID-19. And what the findings that they had were true across all kinds of different subgroups that they looked at. So it didn't really matter what age you were, whether you were male or female, how soon after your symptom onset this occurred, what your baseline risk was. It just didn't seem to make any difference to the direction of that effect. Hydroxychloroquine didn't work for this, all these different groups of patients within this very large, well-conducted clinical trial. So I guess one of the next steps we do is we often combine clinical trials together into what we call meta-analysis. And this also gives us a further idea as to whether this effect that they've seen in this recovery trial is also seen in other trials as well. So this group from, I think it's from Stanford and from Switzerland, have put together this meta-analysis. They looked at all the trial registrations that have been on trial websites. They identified 146 randomized controlled trials. So lots of people are doing these studies, and they included 26 studies into this across a number of settings from ICU through to outpatients. And this is their kind of final findings in this study. And if you notice on this, so this is what we call our forest plot. This is the point estimate of the effect. To the right favors just control. And to the left would be to favour hydroxychloroquine. And this was to look to see whether this saved lives or not. And in general, the point estimate from their modelling suggests that it, once again, similar to the recovery study, that the mortality is actually higher, although not statistically significant, in those who received hydroxychloroquine. So going back to the National COVID Clinical Evidence Task Force, what's their, I guess, conclusion and their recommendation? Pretty clear. It's a red line, not recommended, and that all or nearly all patients would likely decline the intervention, and very clearly states, do not use hydroxychloroquine for the treatment of COVID-19. Okay, next one, Ivermectin. Now, I don't watch Sky News much, but I've been pretty shocked when I've been directed to watch it about specific things such as Ivermectin. And here we have the Kenny report. I presume this guy's Kenny, and he's interviewing this doctor from New South Wales who's called Professor Borody. And Professor Borody is saying that, look, all patients should go on to Ivermectin together with, I think it's zinc and doxycycline, and saying that there's excellent evidence for this. And that we're not saving lives because of not using it. So what's the evidence behind it? Well, there's an in vitro study, as in cell culture study, where, and this actually comes from Melbourne, from the Doherty and the Royal Melbourne Hospital, Vidral, suggesting that in cell culture, the FDA-approved drug Ivermectin inhibits the replication of SARS-CoV-2. So this is kind of surprising because Ivermectin is an antiparasitic agent, but they've shown that it works in these monkey E6 cells, the Vero E6 cells. But when you look more closely at it, it's actually not possible to achieve adequate levels with the current dosing that's being used. So even if you use the highest recommended doses, this is a curve that demonstrates the time in days, and this is the concentration of the ivermectin in the bloodstream or in the plasma, in the blue and the black lines. And then this red line is the dose that's required to achieve the effect that these guys noticed in the laboratory. So even with this very high dosing, the levels that we achieve in the blood, and this is a log scale, at least 100 or so times less than what is actually required to achieve this killing effect. So it's actually very, very difficult to achieve adequate levels with the current dosing. And if you push that dose higher, it's likely that you're going to get some toxicity with the ivermectin. From what I can gather, people like Professor Barodi are citing evidence such as this one, a case series of 100 COVID-19 patients who've been treated with a combination of ivermectin and doxycycline, and they found that pretty much everyone improved. But again, it's completely observational. There was no control group. We don't know whether if all these patients didn't receive ivermectin and doxycycline, they may well have improved just in the same way. So there's actually no evidence to suggest at this stage that ivermectin is of any benefit. It's probably reasonable to run a randomized controlled trial, but there certainly is no evidence at this stage to suggest that it should be broadly used. Okay, convalescent plasma. So this is where a patient who's recovered from COVID-19 donates their blood or their plasma, which contains antibodies that neutralize the SARS-CoV-2 virus. And then this plasma is collected by Lifeblood Australia and can be provided to patients who have current COVID infection and to provide a boost to their own immune response. So before that patient has generated their own antibodies, what you hope is you provide these pre-formed antibodies. So someone else has done the immune kind of response work and you provide that to the patient who's now sick with COVID-19. And there's been, again, looking at the randomized controlled trials, there's really been 2 or 3 of these now, 2 which have been properly published. The first was again from China, a reasonably sick patient group, and they were looking again at time to clinical improvement out to day 28. And once again, because of what happened in China, they had to stop this due to the low numbers or the lack of further cases in China at the time. And notably, they used this convalescent plasma quite late. So, I think the median time between symptom onset to use of the convalescent plasma was out at 3 or 4 weeks from the time of onset. And basically, partly because of, I think, the small sample size, they found that there was no difference between those who received convalescent plasma and control. So again, similar graphs, time on the x-axis, improvement rate on the y-axis, and the convalescent plasma and control were very, very similar. Sorry about that. They did, though, find that in the severe disease group, there was perhaps starting to be a signal of effect. So the severe disease were those who were requiring supplemental oxygen, but not in the intensive care unit. And perhaps convalescent plasma was going to be of benefit if they had larger numbers. But we can't really make any firm conclusion based on that. There's been a study from the Netherlands. Again, not particularly severe patient group, non-ventilated patients in this case. Their primary outcome was mortality to day 28. They actually ended up stopping early due to finding antibodies that were quite high in the recipient group of patients. And so on this graph here, we can see that the patients, and this is the proportion or the neutralizing antibody titer on the left, these patients were actually quite similar to those of donors. So they felt that because these patients already had their own antibodies, it wasn't going to be of any benefit. And then there's been a study from India of about 400 patients, hypoxic patients, and they, amongst about 400 patients, found that, again, there was no difference between the groups who received convalescent plasma versus control groups. One of the things here, though, was that when they did test the antibody levels in the donated plasma, and they hadn't done that prior to the study or prior to giving it to the patients, that the antibodies were quite low. So there's a bit of a question mark about, what happens if you did give high levels of antibodies. And I guess finally to say with convalescent plasma, in the United States, they had this emergency access program for convalescent plasma, which is, again, observational. They didn't randomize these patients. And in fact, they've given convalescent plasma to over 100,000 patients, which is incredible that they've given it to so many, but unfortunately such a waste in that none of these patients were randomized. And even though hundreds, thousands and thousands of patients received convalescent plasma, we still don't know whether it works or not. So again, the National COVID Clinical Evidence Task Force, their recommendation is that we should only use this in the setting of a clinical trial. I've got 2 more slides, I think, and then I'm finished. So in terms of clinical trials, it was mentioned before that I lead the ASCOT study, and this is a trial that's across Australia, and we're planning to actually have a reasonably complicated, I guess, schema whereby patients who are hospitalized with COVID can be randomized within a whole host of different, what we call domains. So patients can receive different antivirals, they can receive convalescent plasma or standard of care, and we're also looking at anticoagulation. So I'll stop there. Thank you very much.
Terrific. Thanks, Stephen. We've had a couple of questions that we'll hold till after Gary's talk. So I'll move straight to introducing our second eminent speaker, Dr. Gary Groman, who joins us from Canberra. Gary Groman is a virologist and a former director of immunobiology at the Therapeutic Goods Administration, the TGA. Gary has undertaken a number of engagements with the World Health Organization, the WHO Health Systems and Innovation Group, the Global Action Plan for Influenza Vaccines, the Essentials Medicines Program, and he led the Pandemic Influenza Preparedness Framework Group. Gary is an adjunct professor at the University of Sydney, and he's a director of the Immunisation Coalition. His interest areas include virology, vaccination, control of infectious diseases, and pandemic planning, and he recently joined the executive board of AVM Biotechnology in the US, advising on projects involving dexamethasone treatments. So Gary, further to Stephen Tong's comments, what other COVID-19 treatments do we need to know about?
Thanks very much for that introduction. I hope everyone can see the first slide. So just the outline of the presentation, just to give you a snapshot of the clinical course, and then dexamethasone and steroids, the evidence for statins, anticoagulants, interferons, and then a whole lot of miscellaneous things like zinc and vitamins and melatonin and selenium. And I thought I'd start with this poll question, so I hope that comes up just to get you engaged. So for the clinical course of COVID-19, which statement do you think is true? Very good. Nearly everyone voted for the first one, which is the most correct there. So the clinical course is really still being worked out, but what we know of it looks like this. For pre-symptomatic patients, we see viral replication prior to the onset of symptoms. So this is not uncommon for almost every viral infection. Then for mild cases, we see viral replication, which then peaks with symptoms coming on, and then the innate immune response. Again, all this is very typical of viral infections. Then we get a slower cellular response. But for severe cases, we find that this curve here tends to rise in terms of the innate response, and we find the cellular responses begin to fall as well. The humoral response goes on for a little while, probably 3 to 4 months. And there was a paper recently to suggest 4 months, but I think most people think it's only about 3 months. But the humoral response, where you might measure IgM and IgG, is simply an antibody response. They're not neutralizing antibodies necessarily, and they're not correlates of protection either. And I think that needs to be taken into account, and much still has to be worked out about that. So antivirals, of course, hopefully will be able to be used in the beginning of the response. Immunomodulators during the course, prophylactic antibodies as well, would all be therapeutic agents that might be able to be used. Now, recently we've seen long haulers, as they're now dubbed, and the long haulers seem to have some significant sequelae. And what's interesting is that many have very poor neutralizing antibody, and I'll show you some data about that. And antibody appears to wane, leading to possible reinfection. And again, we've had reports about that after 3, 4, or 5 months, people seem to have the possibility of getting the virus again. The other thing we see, of course, for severe disease is cytokine storm. And this is why we need to look at treatment so carefully and hopefully come up with a set of treatments that can control the immune response. So what are the long-term consequences? In this paper here by Carlos, they published, which they published online on October 5, the most commonly reported symptom after acute COVID-19 were fatigue, shortness of breath, joint pain, and chest pain. And in addition, and some people have also recently described the sort of mental fog as well, or brain fog, basically confusion. And in addition, there's been specific organ dysfunction also reported, often involving heart, lungs, and brain. And this is very likely due to tissue invasion by the virus, probably mediated by the presence of ACE receptor, and profound inflammation and cytokine storm. And of course, there are also psychological issues which are apparent, particularly during periods of lockdown and so on. But they can be psychological issues after the infection and recovery as well. Now, this paper on neutralizing antibody, there's very, very few of these, but this seemed to be a decent cohort study, at least, studying 175 patients who recovered from mild COVID-19 in China. And neutralizing antibodies to SARS-CoV-2 or COVID-19 varied substantially. So that might help explain, in part at least, the problem with persistent infections and reinfection and persistent symptoms. It is important that to understand that we still don't know what the correlates of protection are in terms of antibody response. They are most likely neutralizing antibody or mucosal IgA. Well, let's look at steroids. And there's been quite a lot of papers published on steroids for all sorts of viruses over time, particularly dealing with injury of the lung. And the steroids, as we all know, modulate the immune-mediated lung injury. So this paper here, published by WHO and JAMA, just compares a whole lot of studies which include dexamethasone. The recovery study is the Horby one, which you may know of, published in the Lancet and New England Journal, hydrocortisone, and others. But what's interesting about them is that none of them are particularly significant in randomized controlled trials, but they do favor steroids. So on balance, you'd have to say, when looking at all these studies in a kind of a meta-analysis, that a treatment, particularly of severe disease, favors steroids for sure. But when you look at the statistical significance of these studies, they're not particularly statistically significant, which is interesting. Some of these numbers are very small, of course. Some are a little larger. But until we get a much larger study, we won't really know. But you can see here the odds ratio is, in some cases, quite marginal. But the conclusion is, on balance, it certainly favors use of steroids. Dexamethasone has also been in the news. We know about the Horby paper in New England Journal, the recovery trial, but it was only used at low doses. Now, either IV or oral treatment. Now, the reason for this is because of the potential side effects, and it contains excipients that create these side effects, which can be difficult to control. So NIH recommendations state clearly the use of dexamethasones at 6 mg per day for up to 10 days or until hospital discharge in hospitalized patients who are ventilated and in those that require supplemental oxygen. They recommend against using dexamethasone. They recommend against using dexamethasone for the treatment of COVID-19 patients who do not require supplemental oxygen. And if DEXA is not available, they recommend alternative glucocorticoids or hydrocortisone. So what about purified dexamethasone? And this here I have to declare a conflict of interest because I'm giving advice to the company that has produced this. And I might add that this particular product, normally used in the treatment of various malignancies, has been used in several cohort studies in Brazil and Germany on compassionate use for COVID patients. So it's essentially a repurposed product being used for various malignancies at the moment. And FDA have made it available for emergency and expanded use on compassionate grounds, particularly for severe ARDS not responding to any therapy. It's a single injection. So these are some of the differences. It's a single injection. It can be given up to 21 mg per kilogram, although the company itself recommends 18. What they've done is eliminated all the excipients, such as benzyl alcohol and parabens found in generic formulations, which limit the use to low daily dosing. And in various studies they've done in vitro and in vivo, it activates or mobilizes supercharged natural killer cells and cytotoxic T cells. So FDA has approved a clinical trial with this particular product. And we just have to wait and see what the phase 1 trial shows. And I've given the website there of the company if anybody wants to look up things any further. I might add the product's actually made in Melbourne, approved by TGA for the use in malignancies and exported to the US. So it's actually here. And if regulators approve, it can be used on compassionate grounds. So what are the suggested mechanisms of actions for controlling the immune response? I think it's rather obvious that in the case of cytokine storm or ARDS, any sort of lung injury, it's very important to be able to modulate the immune response. Now, David Fedson, who I've referenced down the bottom, first recommended this in about 2004, and I think most scientists and clinicians have been looking at this idea, but not necessarily believing it. He argues, and others, that by controlling the immune response, we modify energy metabolism and promote tolerance. We modify various pathways and we accelerate mitochondrial biogenesis or recovery. And he puts a lot of emphasis on cell recovery and tissue recovery by controlling the immune response. Now, all that sounds quite logical. Maintain or restore the endothelial barrier integrity is another one of his favorite phrases. And he speaks of ACE2 angiotensin mass signaling and also type 2 angiopoietin signaling. And again, this makes sense, at least scientifically, in terms of the mechanism of action. I'll put this slide up just to highlight that what happens when the virus infects is that, and attaches to ACE2, it down-regulates ACE2, helping to cause lung injury, and we know that ACE2 helps protect from ARDS. So people are slowly getting an insight into the pathophysiology of COVID-19 acute lung injury. Other immunologists have tried to describe the landscape, and again, this is a paper recently published this year. Firstly, focusing on blood, dysregulated inflammation there in blood and blood vessels, and then on lung. And what people have described are so far cytokine-driven hyperinflammation, lymphopenia, and lymphoid organ failure, as well as myeloid hyperinflammation, dysfunctional type 1 IFN responses, and disruption of the ACE2 epithelium. So this is considered to be basically the immunological landscape causing pathology. But again, there's much here to be discovered. So what about statins? Most of the work done on statins is actually being done on sepsis. And some work has been done on influenza and Ebola and some other respiratory viruses. But the work on sepsis is rather impressive, and I'll just pick this particular one. It's an RCT studies on 100 patients hospitalized with sepsis, 49 treated with statin, 51 with placebo. And you can see here a rather stunning result of organ failure. In those with statin, only 2%, but those on placebo, 24%. So this gives evidence and confidence that the statins might well be useful in controlling the immune response. An in-hospital statin study was done in China by Zhang et al., and they retrospectively analysed 13 to 14,000 COVID cases and found that in-hospital statin use is associated with a lower risk of all-cause mortality. And they have this rather nice diagram in their paper. So the death rate, all-cause mortality, 5.2% versus 9.4% for non-statin users. Digging a little deeper into that paper, and they also looked at a study that combined statins with ACE inhibitors and ARBs versus no treatment. Again, they got very, very good results in terms of p-value with either unmatched and particularly the matched controls. And again, it shows that statins, ACE inhibitors, ARBs might well be useful, and they might be a very useful adjunct to other treatments. When you look at further studies, and there's a number here, and you'll see some here outpatient and some inpatient. The inpatient studies gave very good results, and one outpatient study as well. And again, statin treatment on 28 to 30-day mortality clearly showed that it has an effect. So statins, I think, is something worth considering in a regime of treatment. Another study showing the continued in-hospital use of ACE inhibitors and ARB treatment. And this is those without such treatment and those with, and again, those who discontinued, they were on it to start with, but discontinued, and those that continued. And the mortality rate is much lower and significantly lower. So the beneficial effects of statins and ARBs on cell signaling, we are slowly collecting a body of information. And I won't go through all these, but all these are clearly affected and have beneficial effects from the use of statins and ARBs, either in vitro or in vivo. And there's certainly a whole area of treatment that people need to be looking at, particularly for severe cases of pneumonia. So before going on, I thought I'd give you another poll question. Which of the following may assist patients in the early stages of COVID infection? And obviously this goes to what I'm about to talk about next. Well, not unexpected, a mix of answers, and there's no particularly right answer. There is one answer that probably isn't so right, and that's interferon, but I think, and there's not much evidence for multivitamin supplements, but certainly there is some evidence for melatonin, selenium, zinc, vitamin D, and also anticoagulation. So let's just take that a little further. So there have been quite a few studies on anticoagulation, and NIH in the US have put a lot of money into looking at various anticoagulation studies, And it's quite clear from this graph, the days since admission, those with anticoagulation and those without. And you can see survival since days of admission and also enhanced recovery from this graph in all patients, quite a large number there that was studied, and fairly large number of those requiring mechanical intervention which clearly showed a terrific response there. So anticoagulation should be part of the therapy, particularly for severely ill patients. Interferon, not so much. The recommendation from the NIH is against the use of interferon for treatment of patients with severe or critical COVID, except of course in a clinical trial. And all the studies so far really show no benefit of interferons in patients. And people have looked at alpha and beta and also omega interferons for treatment to date. There's also studies on Middle East respiratory syndrome, MERS, and also SARS-1, those in critical or severe disease. But there's been no particular benefit shown, and so there's been no positive recommendation from the NIH. What about things like zinc? Plenty of studies done on zinc, and we know that zinc has antiviral properties in vitro. We also know that zinc is essential to preserve natural tissue barriers, such as the respiratory epithelium. Zinc deficiency, we know, can be added to factors predisposing individual to infection and progression to severe COVID-19. And there's been a couple of reviews done, and I'll just a summary slide of one of them. The conclusions from this particular review was that zinc is essential to preserve the natural tissues. Oh, sorry, that's basically the same thing. I'll continue. This is a study by the same author looking at a meta-analysis of a number of studies, and there's something like 30 studies. I've only picked 7 or so to show you here. But the effect is rather obvious, whether it's done in children or in adults. When zinc is being used, there's always a reduction of something, or it's an increase in recovery rate, or it's reducing the duration of antibiotics, reducing morbidity, decreased incidence of disease, and so on. So depending on the clinical parameter or endpoint that they're trying to measure in the study, and they are all different, which makes it difficult to really come to a firm conclusion, and also they're not entirely the same product, except they all have zinc in common. There is an effect, there's no doubt. Every single study that's been done as an RTC or a cohort study has definitely shown an effect on respiratory infections and a wide variety of respiratory infections, not just viruses. So vitamin D. So vitamin D has also been touted in the press and so on to be used in the treatment of COVID. And the question is vitamin D status reflecting vitamin D levels and treatment associated with test results for coronavirus disease? And the findings in a cohort study, which I think this is the best one I've found, of 489 patients who had vitamin D level mentioned in the year before COVID testing, the relative risk of testing positive for COVID was 1.77. And the key conclusion there is obviously patients with deficient vitamin D are at increased risk. Having said all that, there's no really good paper out there saying that vitamin D should be added to the regime for treatment, but it is, just in case somebody is deficient for vitamin D. And I think that's one of the reasons that vitamin D is having such an apparent effect. Now, there are a number of other supplements and nutrients, and I'll finish up with these slides, just 2 more. Now, a very good review in the European Journal Pharmacology, which I refer people to, and I'll again just highlight some of the conclusions. It's very clear with the studies on vitamin A, C, and D that there are some immunomodulatory effects that can be measured. They're also useful in case there's a deficiency, and that's rather obvious. We know that vitamin C is a very powerful antioxidant. It regulates DNA synthesis. Again, it's probably more useful if there's a deficiency, but it is useful also for cell recovery. Now, melatonin, I think, is something that people will be studying shortly, at least I hope. So melatonin, we know, is a strong antioxidant. It has anti-inflammatory effects, and it can suppress the cytokine storm. And there's mounting evidence that the initial cytokine storm due to viral infections probably suppresses the production of pineal melatonin. So we know melatonin has high bioavailability. It can penetrate the blood-brain barrier and the placenta, for example. And the cases so far of melatonin combination therapy with other antivirals or some other immunomodulatory agent, there have been satisfactory reports. They're not RCTs, but they're certainly more than interesting. And although I don't have time to go into them, but there's been a number of studies with antiviral drugs and melatonin in combination that significantly reduce oxidative stress and kidney damage. There's been other studies that have shown faster recovery as well. And I think melatonin is something that probably does need an RCT, possibly in combination with other therapies, but I think it's something certainly worth considering because it clearly does suppress the cytokine storm. Selenium is another interesting one. Again, we know it has, in theory, some antiviral effects, at least in vitro. We know it's a good antioxidant. It has some anti-clotting properties, which can be useful. The virus does clot blood cells, and those clots may or may not be a problem in the pathology. We know it inhibits ACE. We know it also has some effect on virus-host cell attachment. So the adequate nutrition of selenium might be the issue again, a bit like adequate nutrition for some of the vitamins. And adequate nutrition for selenium has been shown in other studies is definitely essential for protection against viral infections. So selenium is something that could be considered in the future, depending on the studies that become available. Now the other one, the last one is acetylcysteine or NAC. We know it's used as a rate-limiting substrate for glutathione synthesis. And we also know, of course, that ARDS is one of the main reasons for fatality in COVID-19 patients. And early uses of large doses of antioxidants, including NAC, are thought to be a likely effective strategy in treating severely ill patients. So we know from previous studies it has antiviral properties against influenza A, H3N2 and H5N1. Those studies were done way back in 2004. And there's currently a study going on using NAC and vitamin C together in the management of lung injury. And it is an RCT study, so we'll see what the results are for that. But apart from that, there's nothing else to report on that particular product. So these are just some of my conclusions, and I'll end here. I think there is good evidence for the use of steroids, especially dexamethasone, also statins and anticoagulants for severely ill patients. I think supplements and micronutrients might well be useful adjuncts. We desperately need RCT studies to really happen so we can make firm conclusions about how well a lot of these products help in the recovery from COVID. Melatonin, zinc, selenium, vitamin D supplements are probably useful adjuncts, particularly in the early stages of infection. And the immunopathology of COVID-19 still needs a lot of further research, particularly trying to find out what the actual correlates of protection are to stop reinfection. And this is a personal view, but I think it is likely that we'll have effective treatments before we'll have an effective vaccine. And I know that's probably a provocative statement, but as I'm talking about vaccines next time, I'm going to probably say that again. So thank you very much, and I'm happy to take any questions.
Terrific. Thanks, Gary. That covered a huge amount of ground. We've got a couple of questions. I ask everybody attending to please post your questions in the Q&A button rather than the chat group. We've had just a few questions to clarify, Gary, which particular anticoagulants and ACE inhibitors are recommended as preventative for COVID?
Well, the NIH says almost any anticoagulant will be useful because of the problem of clotting of blood due to the virus itself. We know the virus clots blood in vitro. We're not quite sure about the pathology in vivo, but presumably that's happening just like it does with flu and gives a higher rate or higher risk of heart attack and stroke. So people have looked at aspirin and actually a wide variety of other anti-clotting agents. So I think basically the recommendation from NIH is any anti-clotting agent would be useful. It depends on the patient, of course, what other drugs they're on and what other issues they might have. So that becomes part of the clinical management of the patient.
That's great. And one question raised early in the pandemic, people were stating that ACE inhibitors were detrimental to COVID. So we had some suggestions that it was benefit, some suggestion that it was harmful. Any comments on that, balancing that conflict?
Well, yeah, that's true. That's true. That was certainly the thinking to start with, but people have now, I think, come to realise that if people are on ACE inhibitors, they should continue to be on them, and the effect of them in enhancing COVID-19 is actually quite marginal. The evidence is quite marginal to poor, really. But that was certainly a fair call in the early days. But as I said, there's so much still to uncover here in terms of research on the actual course, the actual clinical course, immunological course, and the pathology of the virus and what it actually does. We're still shooting in the dark at this stage, in my view.
Thanks. And I'd like to bring Steve into this question that Ian Barr raises, and that's are the low number of active and serious COVID-19 cases in Australia going to limit the ability of ASCOT to perform useful trials and meaningful conclusion?
Yeah, thanks, Ian, for that excellent question, and one that we rack our brains about most days. Clearly you need patients in trials to come to any kind of firm conclusions, and it's unlikely, I think, we're going to get that in Australia and New Zealand at this stage. So we are, I guess, two things to say there. One, we are pursuing collaborations with overseas sites and regions. So we're working with the George Institute to try and get to India, where there's, I think 100,000 cases per day at the moment, and to set up some trial sites there. We're approaching other potential partners as well. I still think that even though it's unlikely we'll get sufficient numbers in Australia, it's still important to have an infrastructure that's ready. I think we've seen with what's happened in this second wave in Victoria, there's still going to be an element of unpredictability about the epidemiology. And I don't think it takes that much for further waves to happen. Clearly, there's been issues with the hotel quarantine. I think there's been an element of bad luck there, but it probably only takes 2 or 3 super spreading events for something to really kick off and lead to patients needing to come into our hospital. So if we can be ready and prepared to offer patients, I guess, the cutting edge therapies in the context of a clinical trial and the ethics and safety of a clinical trial, then we should do so. So I think 2 points: we're going to go overseas if we can. And secondly, I still think it's important that we can offer that to Australian patients.
Is there any potential benefit to intranasal remdesivir, which I understand an Australian company is developing? Thank you for that question.
Yeah, look, I've heard of intranasal remdesivir or inhaled remdesivir. I'm not aware that it's been run in any studies or clinical trials yet at this stage. It's obviously, given that it does have some antiviral effect in cell culture and so on, it certainly would be promising, but I don't think there's any clinical data at this stage.
Thank you. And I don't think we've discussed or touched on the potential role for other anti-influenza treatments. Someone's raised the question about what about Tamiflu, or perhaps Stephen and Gary both like to comment on any role.
I'll have a go first. I'm not aware of any clinical evidence to suggest that Tamiflu is of benefit, and my understanding of the in vitro data as well is that there's little evidence. Someone like Ian Barr will probably know better than I will, but that's my understanding. And so because of the lack of strong in vitro evidence, it hasn't particularly been pursued as a treatment in clinical trials either.
Yes, and there's no information on the mechanism of action for that particular antiviral to work on COVID. As Stephen said, there's no in vitro evidence, so there's not much point in taking it any further. I think one of the problems is there's been a lot of stabs in the dark, and people have said, well, let's try this and let's try that, and that's fair enough in a pandemic situation, but only to a point. Unless you really understand the mechanism of action, there's not really a lot of point in shooting in the dark. And of course, it should be done properly through in vitro studies first, and then perhaps some animal studies, and then looking at humans. We need to get the order right. And I think, as was pointed out by Stephen, just jumping at chloroquine or jumping at ivermectin or jumping at some antibiotic or antiviral really doesn't make sense. And it just induces panic all round. And yes, these things are available, but it doesn't mean they're going to work. And in fact, we don't know if they're going to be harmful.
So I guess if I can just add to that as well, Peter, I think that's a really important point. And to take it even further, biological plausibility, so showing it works in cell culture, doesn't necessarily translate to clinical benefit either. And when you go into a study with anything, this is true of cancer or infections, that kind of biological plausibility, even then, probably only 10% of those agents would actually end up being of clinical benefit. So, despite all this understanding the science, I have a very firm belief you've got to prove it in a clinical setting before we give it widely to patients.
So I guess we all know an apple a day keeps the doctor away, but latest maths modelling suggests that one apple every 8 hours will keep 3 doctors away. John Litt raises the question, when will we have a better idea of the immunology of SARS-CoV-2? Gary, can I ask you first to comment?
Yeah, well, it's really an unfolding situation. I think there's so much conflict out there at the moment with various studies. Until somebody sits down and does a proper study on a larger number of people, we won't really know. It'll just be yet again stabs in the dark. And it seems to be a little bit different in various age groups as well. All this really does need to be elucidated. We need to find out, for example, why children are so tolerant of the disease. We're guessing in the dark about ACE receptors and whatever, but we haven't really answered that question, why they seem to be totally immune. The other interesting thing is that if you look at it worldwide, actually 99% of people recover from COVID. 96% of those over 70 recover from COVID. There is a significant percentage of those that are vulnerable or have comorbidities, etc., that have something like an 8% chance of mortality or severe disease. And obviously they need to be cared for. But the fact is the immunology is in fact working in the vast majority of people. We're not quite sure how, and it needs to be studied and understood. But we're so focused on treatment at the moment, I think it's a personal view, but I think we've forgotten to do some basic science. And hopefully there'll be groups around the world that will start focusing on this. We need to understand the immunology if we're going to understand treatment and obviously the pathology.
Stephen, anything to add to that?
Not a great deal, apart from to say, I think we have made great strides. This virus has only been known for 9 months or so now. There's something like, a new paper published every 10 minutes around the world on COVID. So there's almost as many papers on COVID as there are on malaria now. So the exponential increase in knowledge is absolutely incredible. And there are, increasing numbers of good studies coming out that help us to understand that immunopathology.
Thanks. We're covering lots of ground. We've got a couple of questions, I think, that bring us to. We've covered a lot of what evidence there is and what there isn't, but at what stage of the disease are steroids and other drugs used? The sequence of them, as I understand, there are many drugs. Should we use them all together, like Donald Trump, or each one at a stage? And the other question that's related to that is what resources are available for health professionals to use. And the College of General Practitioners have a suite of clinical guidance documents that are updated as needs be. And of course, we've got treatment and screening guidelines by the Department of Health, Commonwealth Department of Health, and of course each state updates. So we have a plethora of information, but sorting through it all is quite difficult to keep up to date. So I guess Steve, you're the trials that you do tries to help sort out what sequence of interventions and at what points they come in. But how close are we to getting some sort of coherence?
I think there will be continued updates on this space. You know, there's lots of studies happening. At this stage, my answers would be, you know, patients with mild disease who do not require hospitalisation. It is just supportive care. There is no evidence to support any additional, you know, therapies. Nothing's been shown to improve outcomes for those patients at this stage. As patients get hospitalised, if they don't need oxygen, again, it's still supportive care. It's at the point at which they need supplemental oxygen. And we've treated many patients like this at the Royal Melbourne Hospital, is when Remdesivir and Dexamethasone come in. So they're the two interventions that have been shown to have some benefit. And then as patients become more hypoxic, there's prone positioning, use of high flow oxygen, and eventually if they need to, you know, they'll get intubated and ventilated. But of all the kind of active therapies we have at the moment, the only ones with strong evidence to suggest they should be used are Remdesivir and Dexamethasone.
Thanks.
No, I'd agree with that. Obviously, you don't use steroids or dexamethasone unless there's, you know, there's a level of severity that would support that. But I think clinicians could consider the use of statins, anticoagulants, things like zinc and vitamins and melatonin and so on, could be considered in the more acute phase of the disease. But again, there's no strong evidence to say that that will prevent the course of the disease turning into a severe disease. But for some people, I mean, studies have yet to be done, but there's some evidence for the use of those things as supportive therapies, not main therapies.
Thanks for that. I think we've covered most of the suite of questions that have come in. There's while anybody thinks of any additional ones they'd like to ask, please send them through to the Q&A button. While I invite each of Stephen and Gary perhaps to give some closing comments of anything further that you may wish to add. Steve, can I invite you first?
Sure. So in terms of the resources that are available, certainly the National COVID-19 Task Force, as I mentioned, is a bringing together of many experts, and they've answered, you know, something like 100 questions now. Should we use such and such an agent in such a setting? And so that's easily searchable and accessible, and includes not just advice for health professionals, but also for lay people, so in easily understandable language. So I encourage you to check out that website. And look, I'm probably, you know, at one of the end of the spectrum of saying that we should, for any experimental therapies, we really should be testing them in the context of a clinical trial. And that's one of the main things I think we've learned from hydroxychloroquine, where in the United States, you know, after Trump's tweet, it was used off-label outside of a trial for thousands and thousands of patients, probably hundreds of thousands. And not only was it not of any benefit, but potentially of some harm. And ideally, if you got the first 4,000 of those hundreds of thousands of patients into a clinical trial, you'd have the answer, and that would then provide evidence for the rest of the world as to how we should treat it. And that's the same with dexamethasone. You know, this recovery trial, I think, has been a shining example of how to do this. Many people were saying we shouldn't use dexamethasone prior to that trial, and I think fortunately for the world, they persisted despite criticism, included dexamethasone, and showed that this was of major benefit to patients. And so pretty much all patients now who come into our hospitals who are on supplemental oxygen will receive dexamethasone. So again, think of the hundreds of thousands of people around the world now who've been given dexamethasone to some benefit because of having done such a study.
Thanks. You reminded me of something that stunned me at the time, and that was at the first hysterical mention of hydroxychloroquine, how quickly that impacted on exhausting the supply in the country, that impacted on everybody who needed it for their relevant conditions. And it was almost overnight. And the harm that can bring was enormous. Gary, your closing comments, if I may.
Well, I'll be brief. I think there are exciting times ahead. I think we certainly need a lot more studies in this whole space of treatment. And I think treatments, if studied well and the RCTs are done, are far more likely to be used and more effective than a vaccine. And while that's a semi-provocative statement, I think we're going to need treatments whether we have a vaccine or not, even a reasonably effective vaccine. So it's very, very important that this kind of work continues, and we mustn't forget the importance of treatment. I suppose the issue around people just suddenly using or deciding to use a particular treatment and saying that vitamin this or a particular product might be useful does gain a lot of traction in the press and social media and whatnot. And we all have to be careful of that, because it'll literally create a storm of its own as it goes into media and press and the rest of it.
Well, that now brings us to wrap up what's been a really great session. I'd like to thank our experts, Stephen Tong and Gary Groman. I'd like to thank you, the audience of healthcare professionals, for your engagement and questions. Thanks to the Immunisation Coalition for bringing such fine educational opportunities to our profession, and our partner PrexHub for hosting the event. This webinar will be uploaded to the Immunisation Coalition website in the coming weeks, and a Q&A document will also be available. In 2 weeks' time, on Wednesday, the 28th of October, Session 3, the final topic in this COVID-19 webinar series by the Immunisation Coalition, will be vaccine developments. Where are we up to, and what are reasonable expectations? Speakers will be Dr. Gary Groman again, Associate Professor Paul Griffin, and the session will be chaired by my dear friend, Associate Professor John Litt. I know you all can't wait, but we just have to. Don't forget to register if you haven't already. Please stay on the line to complete the quick evaluation form. So that's all from me. Make sure you have a good evening and stay safe.